Hey guys, welcome back to my channel. Today is the 23rd of December, so it's the day before Christmas Eve, and I currently got a little bit lost on the track that I was working on, but um, it's expected because it's like holidays and stuff like that, and sometimes your schedule isn't really entirely your own. So I'm just gonna go back and just continue solving questions as I were. I did try to go through some of the pages this morning, but there's a point where you start to realize that solving questions is probably the best way to learn things as you go. So, I mean, I always feel like I haven't really accomplished anything if I haven't done questions that day. So, um, right now, I'm just going to do that. Hopefully, we can solve a couple of them together. And then, like I said from my previous video, I will definitely get a chance during these next couple of days to um, just properly sit down and do like a block of 40 questions with you so that I can really see where my progress is at the moment. There is a new technique that I want to try, which is called just like reading the last two sentences and just using that as your like foundations to figure out what the question is and what answer you're looking for, because I do find that sometimes like I read a clinical vignette and then I have to reread it again, and then I feel like that those are like precious seconds that are being wasted. So I'm gonna try this new method here with you guys right now, where we just read the last two sentences and just see if that kind of helps us answer the questions more efficiently. So that's something I do want to try, and let's just get started. So here we are. And this is the first question that we're dealing with. So, again, they said read the last two sentences, and let's see if that improves our progress or how we think or saves us time. So, where are the last two sentences here? Okay. So, an autopsy examination of the spinal cord shows unilateral atrophy of the neurons indicated in the area of by the arrow. So that looks like the dorsal column to me, and that looks like the area that is involved with the lower limb. Feelings of vibration, pressure, and proprioception if I'm not done. I think I'm done. Hold on a second. Dorsal column. Sure. Dorsal column has what? Vibration, proprioception, pressure, and then temperature and pain. That's the spinal thalamic, right? So we're dealing with that. Okay, so neurological examination. I'm cheating. I'm getting help from my sister. So, neurological examination of the patient when he was still alive would mostly likely have shown which of the following findings. Okay, so I think this is a good question asking me about like the dorsal column, and they want to know what findings. So I do know that it's dorsal column will be proprioception, and the test for proprioception will be Romberg. So that saves us time. So I would think. Well, they're not asking about Romberg, but they're asking about what sense is being affected here. So let's go back and read the rest of the question. A 52-year-old man who's got gastric cancer, treated with subtotal gastrectomy, dies in a motor vehicle collision. Autopsy shows unilateral atrophy of the neurons indicated by the arrow. So I think this is the thing that affects the lower limb, like especially on this side, it's not the outer side, right? Let's make sure that we're actually looking at the correct area. That does look like the dorsal column to me. So yeah, something is going to be decreased. I don't think it's pain or temperature. I don't think it's strength, because strength would be from the corticospinal tract, right? Vibratory sense, yep. And it's not arm, because arm would have been this one, this lateral one. The arrangement in the dorsal column is just like your body's arranged, like your right, like limbs are on the outside or lower limb here, something like that. Let's just see if I remember anything. Decreased positional sense in the ipsilateral leg. Okay, yes, okay, good. So the region of the spinal cord is affected by vitamin B12 deficiency. So vitamin B12 deficiency is subacute combined degeneration. and the dorsal column is definitely affected by it. So, okay, that makes sense because I was kind of lost why we had to know that he had gastric cancer. So, patients who have gastric cancer, they might have vitamin B12 deficiency because vitamin B12 requires intrinsic factor for its synthesis. So, that's like a cool tidbit to remember. I'm just gonna just write that down for my own notes. So, vitamin B12, gastric cancer would be decreased, and you're gonna have dorsal column affection. Okay, so well, we were correct in our thinking that like the leg is what's going to be bothered. So the area indicated in the arrow corresponds to the fasciculus gracilis of the dorsal column. So fasciculus gracilis, and then the next one beside it is the cuneatus. Um, this part of the spinal cord consists of afferent neurons which transmit sensations of proprioception, vibration, pressure, fine touch. So dorsal column equals proprioception, vibration, pressure, fine touch from the same side, lower trunk, and extremities. Atrophy of this area is due to neuronal demyelination, which can be caused by vitamin B12 deficiency and results in decreased function of these neurons, leading to decreased positional sense or proprioception. Another thing that you would do to test for proprioception would be Romberg test. So if you ask the patient to stand up and ask them to close their eyes if they start to lose balance, that's a good test for proprioception as well, which can test the dorsal column for you. So let's take a look at the picture here. Like I said last time, if you watch my video, I mean, Amboss always has these nice like tidbits that help like further your knowledge and understanding of what's going on. It's sometimes good to review these things. So here's a dorsal column, right? So you have 1B is the fasciculus gracilis, right? So that's going to be like your lower limb, while like your, I think it's arms and torso, like they're on the outside, right? So that would be 1A, the fasciculus cuneatus is what it's pronounced as. And then you have the spinocerebellar tract. Spinocerebellar tract, that is, where is that? Two. Okay, oh, those are these guys over here. Enterolateral spinothalamic tract. So spinothalamic is these guys over here, right? Hopefully I'm not dumb. Oops, I am dumb a little bit. Okay, wait. Enterolateral spinothalamic tract. Spinothalamic tract. Okay, that's the stuff that carries pain and temperature. Okay, yeah, so it's on the same side like it would have been here. I just confused that with 5A. What is 5A? Oh, that's corticospinal tract. Okay, okay, yep, okay. Lateral and anterior. So I think I remember reading this morning, or not this morning, like yesterday morning. So you have to know like the pathways and where they cross and where they go up and things like that. So if I remember, I think dorsal column. So we have to remember what's just ascending, which is descending. So let's just start with what's descending. What's ascending is coming from the cortex, from the brain, and that's sending like a motor signal to your muscles to move. So that's the corticospinal tract. So you're going to start off from the cortex, and I believe it decussates in the medulla, and then goes down into the spinal cord, and then it exits through the anterior horn to the neuromuscular junction that's involved. So that's that. Then you have the two that are ascending. So you have fibers that are pain and temperature fibers. Those are going to be from the spinothalamic tract. So pain and temperature fibers, you're going to pick up that information from certain nerve endings. I believe they were the Meissner's corpuscles and the Pacinian corpuscles, if I remember correctly. So those guys, you're going to they're going to relay their information to the area in the spinothalamic tract, and I believe it crosses in the spinal cord. So it crosses in the spinal cord before it goes up. So because it does that, it can be affected by syringomyelia, which is widening of the spinal canal. So when that starts to widen, because those fibers need to cross, that widening can affect that crossing, which is why people who have syringomyelia, they have the absent pain and temperature sensation in the hands and arms, weakness in the upper limb, essentially. Not weakness, just sensory loss in that cape-like distribution. So there's that. And then the dorsal column is also it's an ascending path. So dorsal column, like we said, you have the fasciculus cuneatus and gracilis. They're going to go up all the way to to those areas, the fasciculus gracilis and cuneatus. Like I said, none of this is really sophisticated, but you just like start to learn as you do questions. I mean, like this is the only way I had learned any of this stuff right now, so it works, I think. So then it goes there, and then it decussates in the medulla, it crosses, and then it goes up. So that's what you need to know for these guys. So that's pretty much all you need to know, I guess, to answer questions. So let's see if there's anything else I want to review here. it wouldn't be in the arm, right? Because the arm is not really involved with that area. It's the fasciculus cuneatus that would have resulted in decreased proprioception, vibration, pressure, and fine touch in the ipsilateral arm and trunk. However, this area doesn't correspond to the fasciculus cuneatus. If the arrow had been pointing here, then yes, I would have selected ipsilateral arm, loss of vibration, pressure, etc. Okay, so I like so far this idea of just reading the last two sentences. So let's read these last two sentences. So we have a schematic here. So I'm seeing pi on the ground in the visual defect of the left side. So that would be a right-sided optic radiation upper lesion. Okay. The patient is most likely having a metastatic lesion in which of the following locations of the visual pathway. Okay, I hope I'm not making a mistake here. I believe it's contralateral, right? And we're looking at here's the right eye, right? Here's the left side, here's the right side. So we're talking about a right-sided lower quadrantopia. So pi on the ground. So if it's lower, we're talking about upper optic radiation lesion, right? So I'm only seeing two options here with optic radiation, and it's left-sided. So if it's contralateral, I think it is contralateral. So that would be right-sided optic radiation. Yay! Okay, so it worked. Okay, that's good. That's actually saving a lot of time. I didn't have to read the rest of the stuff. Because there's this like trick that they sometimes do the questions, and some questions are called hook and baits. So hook and bait will like hook you in a direction of thought that would lead you to a different answer. It's just like a way to distract you from what the real question is that they're looking for. So I guess this is a really good way to, avoid that from happening. Of course, I think you are supposed to go back and read to make sure that you didn't miss anything, but this seemed pretty straightforward to me. Like, they're just asking where would the lesion be. So, like we said, pi in the sky, if it was in the sky, right, it would be a lower optic radiation lesion, a contralateral lower optic radiation lesion in what's known as Mayer's loop. And that would be, so lower optic radiation. But if it's pi on the ground, we're talking about an upper optic radiation infection. So the visual pathway transmits visual information to the retina and to the cortex through Brodmann area 17, through the optic nerve, optic chiasm, optic tract, lateral geniculate nucleus, and optic radiation. The superior bundle of the right optic radiation, also known as the right dorsal optic radiation, relays information. So I'm going to write this down so I don't forget it. Right dorsal optic radiation is upper. So you're going to get contralateral, lower quadrantopia. Okay, that makes sense. Okay. Okay. So let's just review quickly. Left optic nerve, right? This is something that wouldn't really have any contralateral issues, or you wouldn't be confused by what's right side, what's left side, or anything like that. Because this is directly affecting the optic nerve. It hasn't crossed anywhere, it hasn't done anything. So it's probably like an embolus that would have caused that. So let's see. Medial portion of the optic chiasma. So that's over here, right? So you have some things that are crossing. So we call this bitemporal hemanopia, and you would have this in cases of a lesion such as a pituitary tumor that is compressing this area. The other thing that you would need to know is a pinealoma that also gives you bitemporal hemanopia. Left optic tract, or optic tract is just going to be contralateral homonymous. And then we have the upper pi in the sky here. So we said that's the lower bundle Mayer's loop, pi on the ground, upper bundle lower loop, or the dorsal part of the optic radiation. Anterior portion of the calcarine sulcus and adjacent visual cortex. So that's here. So you'd have, again, like a homonymous hemanopia over here with macular sparing. And the reason you have macular sparing, right, is because the macula is supplied by both the PCA and MCA. So you would need a stroke. You would need something that affects both of those areas in order to affect the macula. So even when you have this homonymous central scotoma, it's very much a PCA issue that would have caused this. You would need both MCA and PCA affected in order for the full-blown scotoma to occur, I think. Okay, so let's see. Do I want to review anything here? What is Wright-Myers loop? So the inferior bundle of the optic radiations, Wright-Myers loop, is located in the right temporal lobe and transmits visual information from the left superior quadrant of the visual field. So pie in the sky, Myers loop is what's going to be affected. I think I want to move on. Let's just try to fit in as many questions as possible here before the whole world shuts down on us because of coronavirus and Christmas and vacation. I probably will not be able to make any more videos for the rest of the year. So let's solve more questions. Again, let's do this. Last two sentences. Here we go. She is confused and oriented only to time. Okay, so on a CT scan of the head with contrast, 4 brain lesions are seen. One of the lesions is shown. Okay, which of the following is most likely to have prevented this patient's condition? So let's take a look before we get any more details here. The only thing that I'm seeing that's sticking out to me is this ring enhanced lesion. So I'm thinking of what looks like some kind of abscess or something. It could be an abscess, we don't know yet. Let's go back and get some more information from the clinical vignette. So this 53-year-old woman with hypertension is brought to the emergency department 30 minutes after having a generalized tonic-clonic seizure. Okay, so I mean, if she doesn't have a history of seizures, that's something you have to, in an adult, if you get new onset seizures, that could be a clue for tumors or any new problem. But generally, tumors would take you into that direction. That's just something to keep in mind. She has recurrent headaches, dizziness for the last 3 months. Okay. 1 year ago, she had a diarrheal illness followed by a trip to Ecuador. Okay, so again, I'm gearing towards the idea that this is an abscess of some sort. From a previous infection that resolved without treatment. She has not received any medical care. She has smoked 1 pack of cigarettes. Okay. Her temperature is 36, blood pressure 159. Physical examination shows dysarthria and hyperreflexia. Cool. She's confused with and oriented to name and space, name and place. Okay, so which of the following most likely would have prevented this patient's condition? Okay, I'm not really. Let's see, she is 53 years old. Okay, so let's see. They're saying, okay, breast cancer screening. This does not look like breast cancer. To me, metastasis, I only see 1 lesion, really. Let's just double check, make sure I didn't miss anything. Again, I'm not really picking up on anything other than this guy over here. I'm not seeing any fractures in the bone anywhere. This area here looks a bit wonky to me. Avoidance of contaminated food. Could she have toxoplasmosis? I wonder. Vaccination? No. Avoidance of cat feces. Vaccine. I'm not really. It's one of these two. So I'm guessing they are leaning towards toxoplasmosis. So. She had a diarrheal illness following a trip to Ecuador. Diarrheal illness. Like, the most common cause of toxo is contaminated food. I really hope it's toxo, or else I'm gonna look really dumb right now. Okay, so it's not toxo. Neurocysticercosis. Some things weren't adding up with toxo, honestly. I was gonna say, like, her age isn't matching with the clinical vignette. Ecuador thing really wasn't ringing any bells to me. Why I would have picked tinea solium, neurocysticercosis, which is the most common parasitic disease and an important cause of adult onset seizures. Okay, so I need to write that down. So adult onset seizures. So there's two things you would think of, either a tumor or tinea solium, especially if it's a patient that's been living in Asia, Africa, South America. Okay, so, okay. Hyperreflexia, Erlangen-Hans lesion, neurocysticercosis over here. Okay, avoidance of cat feces, let's see. So that would have been toxoplasma, ubiquitous intracellular parasite acquired by ingesting oocyte from water, uncontaminated meat, uncooked pork, things like that. So cerebral cerebral toxoplasmosis can also cause neurological deficits and ring-enhanced lesions. So it looks similar to that, but very unlikely in this immunocompetent patient. Again, like she's 53 years old, unlikely that this is her primary toxoplasmosis infection. And the diarrheal illness just wasn't matching up with that. So thankfully we still answered it correctly, even though it's not toxoplasmosis. But you do need to know that the number one cause is actually not eating contaminated food, like undercooked food. Okay, well, thank goodness for answering using the wrong logic, but the correct answer. So it can be unlikely in this immunocompetent patient, given the patient's gastrointestinal infection acquired from South America. Another diagnosis is more likely, therefore avoidance of cat feces would not have prevented this patient's condition. Anyway, in general though, like cat feces is like secondary, like in the modern world, like Western world, like it's actually undercooked meats are the reason for toxoplasmosis. So let's just read about cancer screening. So mammography is routinely performed in patients and women 50 to 74 years old with an average risk of breast cancer, the most common malignant disease in most postmenopausal women. Although breast cancer has a high risk of metastasizing, most patients have previous diagnosis of a primary disease. Yeah, so I mean, like, there's no history of any like lumps or anything like that. So a point here that you want to keep in mind is that metastases tend to localize in the junction between the white and gray matter, and that's actually where you would find the watershed areas. So the watershed areas of the brain between the ACA and MCA and MCA and PCA, those are the areas commonly where metastases tend to localize. Therefore, breast cancer screening would not have prevented this patient's condition. Is there anything else? So I showed you guys last time how to use the Amboss tool, all the tools that are available to you. So I mean, if you want to review neurocysticercosis, right? You just click it, and on the side right away, you're going to have well, I guess they have all of helminthic infections summarized for you. But if you want to review neurocysticercosis, for example, I mean, it has a table ready for you, and you can take down notes and do, basically whatever you want if there's something that you want to review before you move on to the next question. So let's take a look at cysticercosis. It's a good thing to review, I guess, because it's like part of micro, and you tend to forget parasites over time. So tissue infection with tapeworm larva. Symptoms depend on the infected organ. So it's due to tinea solium. So I'm just gonna, like I said, I always keep like bullet points with me in case like. I mean, there's something just I want to cement it right in your mind. So, neurocysticercosis equals tinea solium. Tinea solium or pork tapeworm, right? Mode of transmission is fecal-oral. Life cycle, okay. Symptoms is caused by cysticercosis. Accumulation in the subcutaneous tissue, muscles, brain, spinal cord, and eyes. Palpable subcutaneous cyst, myalgia. So clinical picture equals myalgia. And most importantly is the neurocysticercosis, in the CNS. So what are you going to have? increased intracranial pressure plus seizures. And remember, adult onset seizures, you want to think of tumors. And since we learned from this question, any neurocercosis would be part of your differential in a patient from Asia, Africa, South America, etc. So ocular cysticercosis, okay, doesn't seem very high yield to know this. Initial test, the CBC will show eosinophilia, okay. Look for eosinophilia for any parasite in general. MRI and CT scan showing multiple small cystic lesions with membranous wall and an invaginated scolex dot sign. Okay, so let's see if we see that on here actually. Let's take a look at our overlay. Okay, so a round lesion is visible in the right temporoparietal region. It has a relatively thick, hyperdense core and is marked by perifocal edema, so that's the edema over here. These findings are typical of colloidal vesicular stage of neurocysticercosis, okay? Okay, so what are we looking for on CT or MRI? We're going to find a calcified cyst or a cyst. Lumbar puncture, will we find anything special? Increased protein, decreased glucose, mononuclear pleocytosis. We can hover over pleocytosis, so it's increased number of cells in bodily fluids, often used specifically to refer to increased leukocyte count. Okay. Confirmatory tests is serum enzyme linked immunotransfer blot assay. Treatment is praziquantel. Okay, so they could have asked us like, what's the treatment, for this? So it'd be a multi-step question. For neurocysticercosis, albendazole plus corticosteroids. So the treatment for neurocysticercosis is albendazole plus corticosteroids. Okay. Prevention is avoid raw pork and inspect this for cysticercari. Additionally, freeze or cook the meat to destroy the viable cysticercari. I cannot say that honestly. Dispose of human feces properly, hand washing before meal preparation. Cool. So let's close this and let's move on to our next question. Okay, we're reading the last two sentences first. So Babinski sign is positive. Is that the... Okay, sensation is decreased below C5 dermatome bilaterally. Okay, C5 dermatome. Okay. An MRI of the neck and base of skull is shown. Okay, which of the following is most likely causes patient symptoms? So what am I looking at here? I am looking at what appears to be some sort of mass over here. Okay, I can see my cerebellum here. I can see the midbrain pons and medulla. There's some kind of mass here. Okay. Okay, so let's go back and see if there's any more clues for us that can help us look for an answer. I did hear some people use a different method as well, as like to look very quickly at the answers so that you would know what you're looking for. So we're dealing with something here that looks like a mass. Could that tumor be causing syringomyelia? Maybe. And we are having sensation loss at C5 dermatome, so syringomyelia could be something here. Amyotrophic lateral sclerosis wouldn't really have a tumor here that would... or whatever this mass is. So that's definitely not it. Cerebellar astrocytoma. Cerebellar astrocytoma, I feel like its position would be elsewhere, like within the cerebellum. Cerebellum seems to be right here and doesn't seem to be affected by anything. Cerebral glioblastoma multiforme, so that's usually within the brain itself. So this doesn't look like a location for it. Then we have foramen magnum meningioma. Now that looks like that could be the answer because we have, we're in the foramen magnum, and it looks like it's a meningioma because it has this attachment here. So, this seems pretty useful, I think, using the last two sentences to help you because I'm guessing this is probably the answer. But let's make sure that's not syringomyelia for now. So let's see. A woman comes to the office because of a 2-year history of upper extremity weakness and neck pain that is worse when sneezing. Okay, she's had difficulty swallowing in the past 8 months. Musculoskeletal exam shows spasticity and decreased muscle strength in all extremities. There's bilateral atrophy of the trapezius and sternocleidomastoid muscles. Okay, neurological examination shows ataxic gait and dysarthria. So the ataxic gait and dysarthria... I don't want to say anything that's going to make me sound dumb. I don't remember if syringomyelia has ataxia. I think it does. I'm gonna go with anyway. I'm gonna go with foramen magnum angioma. So the pattern of the patient's presentation is suggestive of compression in a location that affects both long tracts, cortical and bulbar tracts. Right. So I don't think syringomyelia has any bulbar symptoms. I don't remember exactly. So foramen magnum meningioma, this patient most likely has a foramen magnum meningioma as indicated by MRI. Although the falx cerebri, the suprasentorial convex surface and the sphenoidal wings are the most common locations of meningiomas, in rare cases they can occur in the foramen magnum. Here's going to write a small note, foramen magnum meningioma. As indicated by MRI, early features include neck pain, which is worse with neck flexion, and maneuvers that increase ICP, such as sneezing. Later, patients present with long tract signs. Other findings include spasticity, positive Babinski sign, gait disturbances, cranial nerve palsies, especially between 9 and 12. So that's why the patient here was having like this atrophy. Was it atrophy of the trapeziosternocleidomastoid muscles, which most likely occurs for this patient's this arthrian atrophy. Microscopic examinations will show Sonoma bodies. Okay, cool. So let's go back and just see really quickly why it's not syringomyelia. Syringomyelia is compression with a fluid-filled cavity, right? Okay, compression by a fluid-filled cavity in the central spinal cord and causing neck pain and a cape-like distribution and dissociated sensory loss over years. The sensory symptoms in syringomyelia are often exacerbated by maneuvers that increase intramedullary pressure, so it would have similar clinical picture as in this patient. Muscle atrophy is another common feature of syringomyelia that most likely affects the small muscles of the hand. Okay, other lower motor neuron signs such as fasciculations and areflexia may also be present, while spastic paresis of limbs is possible. Quadriparesis would be uncommon. Okay. I mean, also you don't have like the, while a tumor could cause syringomyelia, the most common cause I believe is trauma, and it's also associated with Cary malformation. So, I think that's. I mean, if you want to go and review the other stuff, then definitely you would benefit from that. So let's just review ALS because I always like mess this one up. So ALS is gonna have signs of both upper motor neuron plus lower motor neuron lesions, right? So you're gonna have hyperreflexia, spastic paresis in the lower motor neuron lesions, including atrophy and fasciculations. Okay, and flaccid paresis. So that's how I know that I'm dealing with an ALS. Plus, you would also have like the reason you might think of this case as ALS is because they are having like bulbar symptoms. So that might also make you think that it's ALS. So bulbar symptoms, right? However, her only lower motor neuron deficit in this case, lower motor neuron deficit, is sternocleidomastoid muscle atrophy, whereas other typical signs are missing, such as muscle atrophy of the extremities and fasciculations. Also, ALS is rapidly progressive disease that leads to life-threatening symptoms such as respiratory failure or weight loss and malnutrition due to dysphagia within 3 years, making ALS an unlikely diagnosis in this patient. Okay. All right. Excuse me. Cerebellar astrocytoma is in children. Okay. So the last two sentences here are tingling pain aggravated by tapping over a swelling. Okay. Which of the following structures is at risk of entrapment if the mass persists? Oh no. I'm looking at the answer to this anatomy question, which is like my weakest thing in the whole world, so. So he has a painless lump near the left wrist and tingling pain over the left hand. So we're seeing a transluminating, rubbery, fixed, non-tender mass. Oh, is that thing? I forgot what it's called from surgery. Lateral volar aspect of the left wrist. What's that thing? How can I forget what it's called? Damn it. There is a decreased sensation to pinprick. Okay. Honestly, I don't know which one of these it's going to be. But I'm guessing we're dealing with the volar surface of the wrist. So, lateral volar aspect of the left wrist. Okay, so it's not polishes, because polishes means thumb. So let's just exclude by basic common sense. Flexor carpi radialis tendon. So we're not dealing with flexor surfaces. So it's one of these guys. And my anatomy sucks really, really badly. One of these two. Well, let's just take an attending tip to give you an extra hint to answer it correctly. So the patient has, oh yes, it's called ganglion cyst. I forgot that from surgery. So the translaminating mass over the wrist, the decreased sensation paresthesia in the median nerve distribution along with positive tunnel sign indicate the cyst is in a location where it's causing compression of the carpal tunnel. So it's asking me what's in the carpal tunnel. I guess that's, oh no, what do I, okay, well, there's no way for me to answer this properly, man. I hate anatomy so much. Okay. Guess they're asking me which of these is in the carpal tunnel, causing compression of the carpal tunnel, which I do not recall at all anyway. So, all right, let's do this. Flexor pollicis longus tendon travels through the carpal tunnel with the median nerve. Other structures that traverse the carpal tunnel are the four tendons of flexor digitorum profundus. All right, so let's just bite the bullet here and study carpal tunnel. See, I don't really like their tables. I'm gonna be very honest here. What is that? Oh, that's nice. Okay, so I like their tables and stuff, but I find that they're too bulky. What do you think of Amboss Knowledge Bank? What's your opinion? Speak up so the mic can hear you.
I like the.
Do you like the tables? Do you like the tables? The tables are good, but I feel like they're huge. They're huge though.
Like, some of them are huge and some of them are like, it's like, there's better tables.
Yeah, there's better tables. Like the tables could be better.
You can kind of make your own table by looking at other tables, and you can make a short one. It's easier for you to understand.
Yeah, I just find them too bulky. Like whenever I see a table, I just skip right through it. Like I can never actually sit down and do, even though it's probably like really beneficial, but like I can't.
Because it covers everything.
Yeah, it covers everything. It's not as high yield. I guess I don't know. I don't like them.
I think it's like you don't even need to study the chapter. Just look
Yeah,
at the
you
table,
could.
and that's it.
Yeah, but for me, like it's just too bulky time wise, right?
I think if you just like read the topic and then look at the table. And the table is all you need after that.
Yeah.
There's just a couple tables, you print them out, and that's all you need to study it.
So another source that I use is called MedBullets, and I mean you can use it for step 1, step 2, step 3, whatever. And sometimes like these guys have more simplified, just high yield bullet points that I prefer. So let's just see. I was just hoping for a cross section of the carpal tunnel. I'm surprised I don't have a picture here. So there's decreased sensation in the thumb, the index finger, the medial finger. So yeah, I should have hinted out at medial nerve. So It's okay, everything is just a review at this point. Medial nerve, okay, so that's carpal tunnel. Okay, pain or paresthesia in the median nerve. Okay, so Fallon test are the things that we use to test for median nerve compression, I think, right? Fallon test and Tinel test. Okay, as well as I just want a regular picture. I'm gonna go to their step 1 instead because I think they tend to have different articles for each. I really like med bullets, like no complaints whatsoever. I think their step 1 is also the same. It's the same information. Okay, well, I'll figure that one out later. Let's just quickly solve one more question because I think my battery is running out. Oh no. Okay, let's just try one more question. So, treatment is initiated with a drug that binds to CD52. Which of the following agents is most likely described? I believe it's Eclizumab. Is that Eclizumab? A 33-year-old woman with a history of multiple sclerosis is brought to the physician because of dizziness and urinary incontinence. Okay, so she has MS. An MRI of the brain has shown several enhancing lesions in the periventricular white matter of the brainstem. Wait, it's one of these two. It's not Eclizumab. Rituximab? I honestly have no clue. Like that, the IMABs and these guys always, or is that Natalizumab? Do you remember what CD52 was? I'm seeing something too. CD52 is surface glycoprotein on mature lymphocytes. Treatment with monoclonal antibody as used in the case of MS and B-cell chronic lymphocytic leukemia. Is it limtuzumab? Oh, okay. All right. No complaints. Alemtuzumab, CD52. Okay, so it's a humanized monoclonal antibody that targets cells expressing CD52 glycoproteins on their surface. Eliminating these cells limits immune-mediated injury to oligodendrocytes. Alemtuzumab is used to treat refractory MS. Okay. Okay, which is consistent with this patient's history. Cool. Okay, so let's go back to the guys that I forgot, like rituximab, CD20. So rituximab equals CD20. And it's used in the treatment of rheumatoid arthritis, immune thrombocytopenic purpura, RTP, chronic lymphocytic leukemia, Waldenstrom microglobulinemia. It does not bind to CD52, so CD20 is rituximab. And then there is the other one that I, for some reason, was thinking about, natalizumab. So what's natalizumab? Is a recombinant monoclonal antibody that targets alpha-4 surface subunit on inflammatory lymphocytes and monocytes, impairing the ability of cells to adhere to blood vessels and preventing autoinflation. This antibody is used in treatment of multiple sclerosis. That's why I was like, okay, I remember hearing about this in multiple sclerosis before, but it's not the drug prescribed to this patient because it does not target CD52 glycoproteins. Okay, so it's alpha-4 surface subunit. Rituximab is CD20. Alemtuzumab is CD52. Let's just go through them all because these are things like you really, like there's no way out of it except memorizing. Satoximab is for chimeric epidermal growth factor antibody that causes EGFR internalization. Satoximab is used in the treatment of colorectal cancer, right? And stage 4 head and neck cancer. Remember that. Okay, so colon cancer. And stage 4 head and neck cancers. It does not bind to CD52 and would not be used in the treatment of choice for this patient who has refractory multiple sclerosis. Cool. Abiximab. Abiximab is a chimeric antibody that targets platelets. Oh yeah, I remember this guy. Oh my goodness. Glycoprotein 2B and 3A receptors, and it inhibits platelet aggregation. So we wouldn't be using that in a patient who has MS. Next is omalizumab, is IgE. Okay, so I remember that guy. That's used in asthma, I think, omalizumab. And that's used as an anti-IgE. monoclonal antibody that interferes with B-cell membrane bound to IgE. It is used in the treatment of moderate to severe asthma. Okay, which is associated with high levels of IgE and is refractory to inhaled steroids and to long-acting beta-2 agonists. It doesn't bind to CD52. What is Basilicimab? Okay, so it's an antibody that binds to CD25. Can you post on the group, please? That meeting will be started in 10 minutes.
Are you talking to me?
Yeah. Can you post on the group that a meeting will be started in 10 minutes? Okay. Basilicimab, CD25 alpha chain of IL-2 receptor. CD25 alpha chain of interleukin-2 receptor on T cells, so it stops T cell proliferation. This mechanism makes the antibody useful as a prophylactic treatment to prevent post-transplantation kidney rejection. Okay, Basilicimab, so I can put in brackets to prevent post-transplant kidney rejection. Interesting. What's next? Bevacizumab. I remember this guy. This is VEGF. Bevacizumab binds to VEGF, so we use it in the treatment of macular thingy, age-related macular degeneration. So it blocks VEGF, so it's used for age-related macular degeneration, as well as renal cell carcinoma. Okay, let's see what's next. Eculizumab. That's the thing that's used in the treatment of anything that has like a complement issue, which was paroxysmal nocturnal hematuria. So that's when the complement starts to attack the red blood cells. So we give that to a patient to prevent basically like complement from doing what it does, which is forming membrane attack complexes. So these destroy the red blood cells in paroxysmal nocturnal hematuria. And the thing you have to remember is that in patients you give this to, because you need the membrane attack complex to like kill off pathogens, you need to make sure that the patient has been vaccinated before you give them eculizumab, especially for Neisseria meningitis or meningitis. So that's something. Eculizumab is monoclonal antibody that binds to complement C5, prevents its cleavage from C5a to C5b, which stops the formation of the membrane attack complex, a MAC complex. So it is used in the treatment of paroxysmal nocturnal hematuria, because it reduces intravascular hemolysis. It does not bind to CD52. So that was a really good question. I love like stuff where you have to like review each and every single wrong answer, and it helps you like refresh everything. So let's just see if we remember any of this stuff right now. So let's start from the bottom up and see if you remember anything. Is there a way for me to like hide the stats or hide the answers? Let's just see if I recall anything without looking. Alright, let's just reset the question. What was the correct answer? Was it lemtuzumab? Okay, so let's see. Natalizumab, that was the thing used for Natalizumab. Oh no. Alpha 4 surface subunits used for the treatment of okay, so it's not used for that. Okay, so Satoximab. Oh my god. EGFR. See, like, oh my god, embarrassing. Viximab was GP2B and 3A, so it's anticoagulant thingy, or anti-platelet aggregation. Omalizumab was IgE antibodies for asthma, okay? IgE monoclonal antibody. Rituximab was CD something, CD20. And Basilicimab, they said that was, wait, what was Basilicimab used for again? I'm gonna cheat. Okay, I was not gonna remember that. CD25. Alpha chain of interleukin-2 for T cells used for patients who are post-kidney transplant. Lemtuzumab is CD52. Bevacizumab is VEGF. anti-VEGF, and if Eculizumab is the anti-like complement 5 thing. Unsophisticated. That's what I call my studying method. But I do have to stop this video here because I do have a Zoom meeting to host for one of my research projects, and I say like I'm pretty impressed actually doing this whole. Listen, Esra, we did 6 questions, and I got 5 of them correct. Esra, I did 6 questions and I got 5 of them correct.
That's great.
But like, alhamdulillah, I just like changed the method a little bit, where you just read the last 2 sentences, so you could figure out like what exactly they're looking for, so you don't get lost in the details of anything.
Yeah.
I think that's actually pretty cool.
Because there's a lot of story in the case.
Exactly. There's a lot of useless information
But
sometimes.
usually the last 2 sentences are like, okay, it's either here's the diagnosis, what's this, or it's telling you what is the diagnosis.
Exactly. All right, so I will see you guys my next video. I'm not sure when that will be because everything is closed here for Christmas, New Year's, Boxing week, and things like that. But I hope we can continue this series of solving questions together. It's keeping me motivated and keeping me on track. So I hope you guys are enjoying this video series, and I will see you guys in my next video, and happy holidays.